This is Healthcare Now Radio's Talking the Walk. Come along with us as host Tom Testa and his guests discuss the strides being made toward actionable changes in the industry. It's a fast-paced 30 minutes, so keep up. And now, here's Tom Testa.
Hello, everyone, and welcome to the debut episode of Talking the Walk. I'm your host, Tom Testa. This show is all about diving into real conversations that inspire, challenge, and move us forward. No shortcuts, just authentic journeys. Let's take this first step together and start walking the talk. Joining me today is Rob Stuart, who is the founder and president of Claim.MD, a leading EDI clearinghouse helping to streamline the billing and collection process for providers, payers, and software vendors. Designed with the provider in mind, Claim.MD's cost-effective and robust product and service offerings are designed to meet provider collection goals. The company's system of tools is designed to help providers send clean claims the first time and offer visual tracking to easily see issues and collection trends as industry billing situations change. Rob, welcome to the inaugural episode of Talking the Walk.
Thank you, Tom. I'm glad to be here.
Well, Rob, please tell our listeners a little bit about you and your journey leading up to your current role as founder and president of Claim.MD.
Well, first of all, thank you for that lovely introduction. If I wasn't president of Claim.MD, I would be applying for that position right now after hearing your introduction. The one thing that you said in your introduction that I resonated the most with is that we are provider-centric. There is no single observation that could make me more proud. I often say that so many people in the medical technology industry were software developers or they were database specialists, and then somebody had a grandfather that knew COBOL and they got called in to rescue an old system on a mainframe somewhere. Very few people started out organically saying, I want to spend my life in medical data communication. But I was very fortunate in that I was coming of age in the early 80s, and that was the same time that the personal computer was changing the world.
Mm-hmm.
We used to think of a personal computer as something that you carried around on a dolly, and now we have one in our pocket. So it was a very different world. The first personal computers didn't even have hard drives in them. And that was during the era when baby boomers were first aging into Medicare. And I was working with some people who had some very cool technology. And I looked at that technology and I could see a fix for every problem in the world in it because I loved the technology. And at the time, somebody went to the director of the college, the information department, and said that they wanted someone to make the doctor's computer talk to Medicare over the phone. Nobody had ever heard of such a thing. I went to see that doctor, who was an ophthalmologist, a surgeon, and come to find out the cataract lens reimplant surgery had just gotten revolutionized a year or so before that. And this doctor was doing surgeries hand over fist as fast as he could move, restoring vision for seniors. And Medicare at the time did not have the capacity to process the volume of claims that ramped up rapidly as baby boomers aged into the system. So one thing people learn about me when they work with me is I always ask, where is the pain point? What's your problem?
Mm-hmm.
Why am I here? And come to find out, at that time, Medicare was paying $2,000 an eye for cataract repair because there was so much demand and it was such a newly revised procedure. Unfortunately, they were taking 9 months to pay the claims when they were submitted on paper because I always envisioned a facility surrounded by a moat where they had people underground typing into dumb terminals as fast as they could, rekeying these volumes of paper. But it took 9 months to process a surgical claim right then. But the doctor's expenses happened on Friday was payroll. Every day he did surgery, he had to pay the surgery center, the anesthesiologist. And then the first is going to roll around, and that's rent. And if you don't get paid for 9 months, as some providers experienced earlier this year during the cyber terror disruption, that can make a surgeon panic pretty quickly. That's how I got called in. And I looked at it, and I was raised in a med surg clinic, but I didn't know the finer points. But I already had a heart that loved providers that were helping patients achieve wellness. So when he called me, I came in and he said, "Don't worry about what you don't know. Just ask me questions as they arrive. But I want you to make this data appear in that computer over a modem." And these fabulous tools that I had gotten exposed to very young in life were originally for oil and gas. And I said, well, I can do a medical application. And I did it. So it took me maybe 3 weeks to write the system, which was a very crude first draft. But it was a bridge that went from one side of the chasm to the other. And it didn't matter that it was crude, because this was the early 80s and nobody had ever seen anything better. Mm-hmm. So 21 days later, that surgeon got paid for 9 months worth of work after I pushed the data through. Because at that time in the industry, Medicare was just beginning to offer providers incentives for filing electronically. And the main one was paper claims are tantamount to a message in a bottle tossed in a river, where electronic claims are a software digestion process. Mm-hmm. And you will have a rejection back within 72 hours if it's going to reject. Otherwise, you're sitting on the payment floor for 21 days before your funds are dispersed. And that is how I came to write what became a medical clearinghouse, is solving a cash flow problem for one doctor.
Wow, that's an amazing story. It sounds so. At the time, were there not many or any doing this electronic claims process?
We did not have the word medical EDI for another 5 or 7 or 10 years, and you look that many years ago back, it's like geologic time. How do you say when we coined what word? The obvious issues were that Medicare was administered. I don't want to get all technical, but Medicare is not a company. Medicare is a concept, and it's a funding plan, and it's administered by companies who are the carrier for that region. Mm-hmm. Is typically how it works. There's minor exceptions. At that time, every state was approaching electronic data interchange differently. And there was one federal rule with Medicare carriers, is that to be a Medicare carrier, you had to allow providers to submit claims electronically, because federally they were trying to encourage that. Every Medicare carrier in the United States had a little crude, difficult, cranky, creepy PC application where you had to press Shift F12 and tab 16 times and do all of this. This was in DOS version 2.0 days. And they had to give that application away free, where providers could rekey their claims and they could go electronically. But that was a lot of data. and you were always behind, and nobody said, we want to hire an extra department to go do double entry of data. Now, what we would equate this to today are small providers or even larger providers who have one-off tasks to do from time to time, and they will go to a payer's website because now payers have provider portals on their website and sign in with their credentials and type in a claim.
Mm-hmm.
In fact, Claim.MD operates those for several payers as well. But in the old days, those payers had a very crude PC application that you could sit down and type claims into, and then they would use a Hayes 1200 baud modem to dial into the Medicare carrier and perhaps transmit your claim successfully,
Mm-hmm.
because we weren't that good at data communication yet. So that is the environment, and there were no national standards. So anybody that wanted to write software would have to get specs from all 50 states of, okay, what local format does your Medicare use? So that set off a period of evolution over time where we had the national standard format, which was a fixed width format. Then people derisively began calling it the national similar format because each state then changed it to suit their own needs. And then we got ANSI standards, and we've been with that ever since. And those do change through time as well.
Excellent. Well, if you're just tuning in, you're listening to Talking the Walk on Healthcare Now Radio. I'm Tom Testa, and joining me today is Rob Stuart of Claim.MD. Rob, I want to jump into the heart of our discussion here about why it's critical to be able to track a medical claims history. I know you touched upon a great history there of how it came to be and why it's significant. But claims often take a complex journey from submission to resolution, creating challenges for providers, patients, and payers when key details are lost along the way. Rob, how does having access to a claim's complete history help simplify this process and improve outcomes for everyone involved?
Thank you, Tom. That's a great question. And as you were asking, I wish you could have seen the animated images that were popping into my head.
Okay.
Because I spent at least a decade explaining this concept before people were truly aware of it. And I've sat with people who are medical billing professionals, and I've said, oh, so how do you see your claim history? And they just look at me and they say, oh, we can do that in our system. And I say, yes, but can I watch? And they will sit down and they look like an old-fashioned egg beater that's spinning around, and they're just whipping. And they have no concept of how many keystrokes they're making to go find one claim. And they're looking for reports about that claim that 10 years ago used to all get printed in an obligatory manner. And you don't need those reports when they're available and handy. You need those reports down the road when you're aging your accounts receivable. And literally in every provider's office I was in, there was a box behind a door that had gathered dust in between all the pages as they accumulated on it. And somebody would be looking for a claim that hadn't paid and trying to get it paid before they billed the patient. And then somebody had to go dig that box of old dusty paper out. And I'm old enough, I've got enough analogies that the most expensive peripheral device you can add to a computer is a pair of eyeballs. So we're putting that pair of eyeballs on dusty paper, and we're spreading it out in conference rooms, and we're looking for one magic piece of paper that has an acceptance number, because that acceptance number sets a timely filing clock. Your deadlines begin ticking from that moment on. So what I was finding, because at Claim.MD, I've done everything over time. and I was running support at that time. And I saw providers genuinely distressed because they had submitted a claim 15 times. They might have thought the patient's middle initial is why it wasn't paid. You see people all the time that will submit a claim 15 times just to see if they'll catch the payer in a better mood and it'll pay that next time. Or they'll think maybe it's a glitch. I'm going to let this go through one more time. And that is failed logic. They are just getting closer and closer to writing that charge off every day, that they don't have the tools to see what they need to take the action that makes sense. And explaining that over and over and over in support, I'm a developer. So I came up with the idea of let's track these claims through time. And every single submission of them, let's make a note of exactly what changed between submissions. Because what was happening is every clearinghouse in the industry treated each submission of every claim as a whole new stateless world with no context. And the way that affected providers is they would get mad at us as the clearinghouse, and they would say, I'm looking at 47 responses that say that claim was accepted and it's not paid. And I say, yes, but those were preliminary. It made it through the front end edits. But do you have an internal control number where it went into the payment system at the payer? Well, no, but I've got all these 47. Those don't mean anything unless you can see that claim went into the payment system. So in speaking with Nahal, who is my counterpart at Claim.MD, that I'm very free with making promises of magnificent things, and he's the one that makes them come true. In mentioning that to him, he looked at me and his eyes were a little twisted and crazy, but he said, you can't do that with the architecture because everything has an ID, and every time it submits, it rolls over to a new transaction. And he said, the only way we can do that, it would require a 1-year rewrite where we totally rewrite our architecture, where we're not looking at a bill or a claim, we're looking at a visit that we track through time. So we completely changed our architecture. And then from there, the history that we envisioned in one English document with a timestamp and user IDs of everything that's been done is available in a claim history document. And every change that was made to the claim. So we began by marketing that as a tool that providers can use for surviving accounts receivable aging, because you could send that level of history to any insurance company in the world, and they could not argue with it because they were looking at their data and their internal control number that sets the appeal clock or the timely filing clock. Mm-hmm. So we gave providers visual access to the data that they needed to solve that problem, instead of submitting the same claim over and over like Groundhog Day. Now the providers could see the transcript of it and control it instead of being a victim of it.
Well, I'll tell you this, two takeaways that, after listening to you there is, one, I think we all need a Nahal, it sounds like.
You can't have him.
So, I mean, this is right. Someone who I need someone to help make my dreams come true as well, I think, too. So this is, that's fantastic. And two, what I'm listening to is, as this whole process is, I'm obviously not a provider, I'm not a payer, but I'm a patient, just like you are. And a lot of this ultimately impacts the patient, which should be the most important person in this whole, ecosystem, having to reprocess claims over and over again, insufficient information, and at the end of the day, it's delaying my treatment.
Yes. And it's about access to care,
Right.
because it doesn't matter if we have the best system or the worst system or one in the middle in the planetary alignment. But if you personally don't have access to care when you need it, then it didn't work for you.
That's right. That's right.
There, a brief aside, I do have a wonderful staff at Claim.MD. And because I understand the system, the medical system in general,
Mhm.
one of the ways that I give back to the world is by advocating for patients and families in uncertain times that involve healthcare. And that's one of the most fortunate things that any of us that work in the industry and consider ourselves to be experts or professionals could ever do, is to see some patient care delivered. And that's where you begin to reset all of your values, because then it makes it clear why we're doing this, everything that we do.
That's amazing. No, that's amazing, Rob. I know we've got a few minutes left with you. I want to look ahead, right? I know we've got a lot we could talk about, and I'd love to have you back on the show again sometime to dig deeper into the claims process as well. But I want you for the last couple minutes to get your crystal ball out and talk about what might be in store as we head towards a new year. What trends do you see specifically set to impact, the medical claim space in 2025 and possibly beyond? What are your thoughts on that?
Well, Tom, at the risk of sounding too scripted, you led me directly to the answer of that question in the previous question.
Okay.
Um, in the industry right now, what we're seeing is, attachments, appeals. There's all kinds of things now that the medical EDI industry is maturing. But we've been doing those for a long time. And so everything was disrupted earlier this year by the cyber terror attack. And that affected every single member of this industry and many consumers. So right now we're all regrouping and saying, okay, where were we a year ago? What were we excited about? And what do we want to build for next year? As we see it, the largest gap right now is that providers are struggling greatly with prior authorizations. And we have such miraculous care that we can deliver. But if your insurance company hasn't approved it, you're not going to get it. And providers have whole departments that's all they do is submit data about care that needs to be delivered, where the physician wouldn't be dedicating resources to writing it up, justifying it. In the last question, I commented about being an advocate and watching care be delivered. But if that care never gets authorized by the payer, the provider is never legally able to do it and get paid. So we're going to turn our sights to prior authorizations in 2025, because it has occurred to us that by giving tools to providers for prior authorizations to speed that up, to make it more directly equated to the billing process itself, we're not just helping our providers, we're helping our providers deliver care. And for a financial organization, that's something that makes me very happy to say.
That's great. Well, Rob Stuart, thank you so much for joining me today. Your insights and stories, they've set the tone for what the show is all about, and hopefully will continue to be all about as we go beyond episode number 1.
Thank you, Tom, for this wonderful opportunity and the great job you're doing with bringing insightful material to the world.
Thank you, Rob. Appreciate that. And if you'd like more information on Claim.MD or are interested in connecting with Rob and his team for a free demo, visit their website at Claim.MD. Thanks for joining us today as we begin our journey of Talking the Walk. Tune in to hear us weekdays at 8:30 a.m., 4:30 p.m., and 12:30 a.m. Eastern Time. You can also find all our episodes on the Talking the Walk program page on healthcarenowradio.com. If you are someone who is walking the talk, we want to talk to you. Connect with me on LinkedIn or fill out the show's contact form on healthcarenowradio.com. Until next time, keep walking your talk. I'm Tom Testa. Take care, everyone.